مساء الخير جميعا وشكرا لحضوركم للويبينار الثالث للجمعية العربية لأمراض الغدة الدرقية. يسعدني أن أكون الشيرمان في هذه الجلسة ويرافقني فيها الدكتور طارق الهد. نستضيف خيرة من المتحدثين. ستبدأ معنا الدكتورة البروفيسورة غادة الصغير، وسيشاركنا بعدها الدكتور علي الزهراني والبروفيسور مالك جويعد. الدكتورة غادة الصغير هي بروفيسور of internal medicine واندوكرينولوجي من جامعة المنيا في مصر. هي حاصلة على البكالوريوس واختصاص الباطنية من جامعة المنيا في مصر، والزمالة في الغدد الصم السكري من جامعة نيغاتا في اليابان. تفضل دكتورة ولك المنصة.
السلام عليكم ورحمة الله. Thank you, Doctor, for the very nice presentation. It's my honor to be a part of this grant event, and I want to thank Professor Nasser El-Johani, who invited me to participate in Saudi Academy Council, which is a part of Arab Association Academy. I will start to share my screen. Updates in the management of benign thyroid nodule. Thyroid nodule is a discrete lesion within the thyroid gland that's radiologically and histologically different from the surrounding thyroid parenchyma. Both benign and malignant. نعم هلا. سنتر الكاميرا. كده تمام.
سنتر.
Both benign and malignant thyroid disease can cause thyroid nodule. Thyroid cancer occurs in 7 to 15% of any thyroid nodule. Actually, thyroid nodules constitute a diagnostic challenge because we need to exclude thyroid malignancy. Thyroid nodule diagnosis will go through rapidly for diagnosis of thyroid nodule. After that, we'll proceed to the management of benign thyroid nodule. Thyroid nodule evaluation.
تلغي الكاميرا.
نعم.
تفضلي دكتورة تفضلي.
Thyroid nodule evaluation or diagnosis need physical examination plus history. Thyroid ultrasound, which is crucial for diagnosis of thyroid nodule. Thyroid function tests, especially assessment of thyroid stimulating hormone TSH, radioactive iodine uptake and scan. Finally, fine needle aspiration biopsy when indicated. Approach to the patient with thyroid nodule, either palpable nodule discovered by the patient or physician, or incidental nodule discovered on imaging. Start by history of rapidity of growth onset. If there is family history of benign or malignant lesion, history of previous radiation, then physical examination about the size, consistency, tenderness, any adenopathy, and the assessment of thyroid function test, mainly the TSH measurement. After the TSH, thyroid ultrasonography. Actually, TSH measurement is the first step we start with. Low TSH, if we found low TSH level, so the next step is radionuclide thyroid uptake scan. According to the scan, if there is hyperfunctioning or hot nodule, this means hyperthyroidism, either subclinical or clinical, then the final treatment is radioiodine ablation, surgery, or antithyroid therapy according to the situation. If there is cold nodule or from the start normal or high TSH level, we proceed to the ultrasound, and according to the ultrasound characteristic, if there is suspicious ultrasound features, we look for the size. If the size is below 1 centimeter, repeat ultrasonography in 6 to 8 months. If the size equal or more than 1 centimeter, we proceed to fine needle aspiration biopsy. So again, thyroid nodule, assessment of thyroid stimulating hormone, normal TSH or elevated even within the upper normal range is risk factor for malignancy. According to the ultrasound characteristics, we proceed to FNA. If it's lower or suppressed TSH, so there is thyrotoxicosis. The next step is thyroid scan. According to the result of the scan, if hot nodule, we proceed for surgery or radioactive iodine therapy, cold nodule. So again, the ultrasound characteristic and the FNA is if indicated. Very important to say that don't use nuclear medicine thyroid scans to evaluate thyroid nodules in patients with normal thyroid gland function. So no need to do thyroid scan in patients with normal or with hypo TSH elevated. Thyroid scan is needed only if the TSH is suppressed. Nodule ultrasound characteristics. Actually, ultrasound, as we said, very crucial for characterization of the nodule. It gives us idea about the size, echogenicity in relation to the strap muscle around the nodule, either isoechoic, hyper or hypoechoic. If it's hypoechoic, this means it's abnormal tissue of this nodule and indicate more for malignancy. Also, it gives us idea about the margin and if there is extrathyroidal extension, any micro or macro calcification. So this characterization of the ultrasound, solid or hypoechoic nodule, the first one. Cystic nodule with solid hypoechoic components, this high suspicious for malignancy. If the size more than or equal to 1 centimeter, refer to FNA. If less than 1 centimeter, follow up ultrasonography 12 to 24 months. If there is isoechoic or hyperechoic nodule with partially cystic nodule with eccentric solid area, this intermediate suspicious, we do FNA if the size more than or equal to 1.5 centimeter. Low suspicious if it's spongiform or partially cystic nodule without eccentric solid nodule. We refer to FNA if the size more than or equal to 2 centimeter. Purely cystic nodule, no need for FNA, but we can do aspiration if large symptomatic cyst. This is a picture of the ultrasound from down to up. This benign nodule, the risk of malignancy, less than 1 centimeter, it's purely cystic. Very low suspicion, it's a spongiform nodule. Likely it's normal thyroid tissue inside the cyst. Very low suspicion of malignancy risk less than 3%. Low suspicious nodule in case of hyper or isoechoic nodule with regular margin, the risk of malignancy 5 to 10%. Intermediate suspicion, the risk of malignancy 10 to 20%. In hypoechoic solid with regular margin. High suspicious nodule, the risk of malignancy about more than 70 to 90% if it's hypoechoic or deeply hypoechoic, plus microcalcification, irregular margin, extrathyroidal extension. This is the thyroid classification system. They used this system in 2017 about the same criteria of the ultrasound, but put in a score called the thyroid classification system. They classified from thyroid 1 to thyroid 5 according to points given for each characteristic of the nodule. So thyroid 1 and thyroid 2, no need for FNA. Thyroid 4 and thyroid 5 indicated for FNA. Thyroid 4, FNA if the size more than 1.5 centimeter, and FNA more than indicate if more than 1 centimeter in thyroid 5, but in mildly suspicious FNA done if the nodule more than 2.5 centimeter. Usually we have this classification from the radiologist also on our office. The gold standard for diagnosis, cytological diagnosis, is the fine needle aspiration biopsy, ultrasound guided fine needle aspiration biopsy. But cytologic sample is usually labeled diagnostic when it contains a minimum of 6 groups of well-preserved thyroid epithelial cells with at least 10 cells per group. This is sufficient for examination. We can look for this cytology report. The diagnosis is no malignancy. But if we focus on the cytology reports, there is marked hypocellularity. Marked hypocellularity indicates that it's non-diagnostic. It doesn't exclude malignancy and need to repeat this FNA after 6 to 12 weeks. So cytology report, we must look for the cytology, must be enough cellularity, as we said before, to say this malignant, no malignancy or not. According to the FNA finding, we have the Bethesda system for reporting thyroid cytopathology from 1 to 6, non-diagnostic or unsatisfactory, the risk of malignancy 1 to 4, benign, the risk of malignancy from 0 to 3, atypia of undetermined significance or follicular lesion of undetermined significance constitute 5 to 15% risk of malignancy. Follicular neoplasm or suspicious of follicular neoplasm risk of malignancy, 15 to 30%. So stage 3 and 4, this is called the indeterminate nodule, which is the dilemma for the result of the FNA. 5, suspicious for malignancy, the risk of malignancy 60 to 75, and 6, malignant, final malignancy, and the risk of malignancy very high, up to 99%. So what we do according to this is the FNA, and this is what is the management after. If you are in the category 1 non-diagnostic, repeat FNA within 6 to 12 weeks. Even when category 2 benign, so follow-up ultrasonography in 12 to 24 months. Category 5 and category 6, actually surgery, and the dilemma again in category 3 and the category 4. This is, we look for, if we have indeterminate nodule, as we said before, refer back again to the ultrasound finding. If there is suspicious criteria of the ultrasound, refer to diagnostic lobectomy. Also, if the size more than 4 centimeters, again, refer to lobectomy. Why we refer to lobectomy in this, if the size is more than centimeter? Because of the low sensitivity of the fine needle aspiration biopsy in big-sized nodule, more than 4 centimeters. If there is an ultrasonography finding is not suspicious for malignancy and size not enlarged, if molecular testing is available, we choose the test based on availability and informed patient preference. If we have this molecular testing and we see the molecular testing result, if come with benign, so surveillance again, repeat ultrasound from 6 to every 6 or to 12 months. If there is increase in size more than volume of the nodule, more than 50%, or increase a dimension, at least 2 dimensions, more than 20%, we can repeat the FNA again. If molecular testing is not available, so refer if there is category 3, repeat FNA in 6 to 12 months. If category 4, referral for diagnostic lobectomy. So according to the FNA, non-diagnostic can occur in 50% of cases, benign in 70% of cases. Benign 70% of cases, if it's asymptomatic, no need for treatment, just follow up. So no interference with asymptomatic benign nodule. But if benign nodule symptomatic, which is happening in the minority of cases, causing swallowing problem or pressure and toxic adenoma or growing in size, if there is personal and psychological impact, we can consider treatment, either surgery, radioactive iodine therapy in case of toxic nodule, ethanol ablation, and thermal ablation, malignant tubule surgery. So what's the treatment option of benign thyroid nodule? If we have benign thyroid nodule and asymptomatic, as we said, no need for treatment. But if symptomatic, mass or hormonal effect cause motor concern or anxiety, we have 4 options of treatment. Thyroid hormone suppressive therapy, radioactive iodine for autonomous functioning thyroid nodule, surgery, either local or total thyroidectomy, chemical or thermal ablation. Surgical management is the most common and effective treatment of thyroid nodule, especially indicated in benign nodule more than 4 centimeters, especially if continued to grow and causing progressive symptoms, including dysphonia, dysphagia, or dyspnea. As we said, that FNA has low sensitivity in big-sized nodule. But what's the problem of surgery? Risk of individual complication from 2 to 10%, hypocalcemia, recurrent laryngeal nerve palsy, bleeding, post-operative infection, other drawback, long-time hospitalization, scar formation, iatrogenic hypothyroidism, difficulty in reoperation. What about medical management? TSH suppression therapy with levothyroxine shows modest clinical efficacy, but with increased risk of adverse effect from iatrogenic thyroid causes, which include atrial fibrillation and reduced bone density, especially in elderly. Therefore, routine TSH suppression for benign thyroid nodule is not recommended. Adequate dietary iodine intake, about 150 milligrams daily, has shown some benefit in reducing nodular size. However, it hasn't been shown whether dietary modification can affect the risk of thyroid malignancy. And this is a recommendation of American Thyroid Association, 2015, recommend that routine 2-SH suppression for benign thyroid nodule in iodine sufficient population is not recommended. About the thyroid ablation, we have chemical ablation and thermal ablation. Chemical ablation by ethanol or polydiconal, laser ablation therapy, radio frequency, microwave, and high frequency ultrasound. What's the pros and the cons of ablation in benign? The pros, no lifelong medications, يعني هو thyroid preserving, no need for replacement after the procedure. No general anesthesia, less complication, no surgical scar, no admission, no downtime for work. Cons, gradual volume reduction, repeat sessions in untreated portion, large tumor or marginal regrowth can happen. We start with ethanol ablation therapy. According to the Korean Society of Thyroid of Radiology, use iodine concentration sterile ethanol 950% or 99%. Ethanol or polydiconal injection, this is a sclerosant material also used in kidney cyst. So percutaneous ultrasound, guided installation of a sterile 95% ethanol into the thyroid nodules leads to cellular dehydration, thrombosis of small vessel, protein denaturation, cellular coagulation necrosis, and subsequent reactive tissue fibrosis. It has been used for treatment of autonomously functioning nodule or treatment of cyst or cystic nodule. Indication of ethanol, if there is a recurrent cyst in case of pure cyst, benign thyroid nodule with large cystic part, autonomous nodule in patients who are not amenable to conventional therapy or in situations small-sized nodule and I want to preserve the function of the gland. Autonomous thyroid nodule in patients who refuse conventional therapy. This is the indication of ethanol injection. Before the procedure, in case of predominantly cystic nodule, we need, or spongiform appearance of the nodule, we need one fine needle aspiration or benign fine needle aspiration before ethanol injection. So in case of spongiform appearance or cystic nodule, we need one benign FNA. But in case of solid nodule, at least 2 benign FNA results are essential before performing the ethanol procedure. The procedure, a transismic approach is recommended. The needed tap should be placed in the cystic part and the liquid or viscous content should be submaximally aspirated and aspirate about 90%. Ethanol concentration 96 to 99% is injected. Usually we inject less than 10 ml or about 50 to 70% of the aspirated fluid. The ethanol is then re-aspirated after 2 minutes. Injection must be stopped when the patient complains of pain or heat sensation. This thyroid cyst starts with the pre-treatment, the size 70, volume 17.6 ml. After 12 months, the volume decreased to 0.4 ml, which is a very nice result. Complication of ethanol ablation, localized pain, hematoma, facial flushing, hoarseness, dysphonia, temporary hyperthyroidism. Ethanol ablation of solid nodule has limited therapeutic effect and may require multiple sessions. Thermal ablation technique, we have 4 techniques: radiofrequency ablation, microwave, laser, high-frequency ultrasound ablation. Indication for symptomatic nodule, as we said, dysphagia, feeling of oppression, benign nodule with cosmetic indications, autonomously functioning nodule in selected patients who are not suitable for surgery, if patient refuse conventional therapy. Thermal ablation, in 2017, thyroid radiofrequency guidelines with Korean Society of Thyroid Radiology and the European 2020 European Association of Clinical Practice Guideline for use of image-guided ablation of benign thyroid nodule. The objective of thermal ablation is irreversible coagulative necrosis of the thyroid nodule with subsequent reduction in the volume. In thermal ablation of thyroid nodule, the target temperature is at least 60%, 60 degrees centigrade in ablation region, at which a thermal effect almost immediately and subsequently bring about irreversible damage to the nodule. This is a laser and radio frequency, high frequency ultrasound, the different duration, about 50 to 30 minutes, 50 to 40 in radio frequency, and about 55 in high frequency ultrasound, also the cost and the contraindications. Again, the recommendation before doing this thermal ablation, again, we must have benign FNA from the nodule, with exception of spongiform nodule and the pure cyst thyroid class 2, recommend we can get one FNA, benign FNA. They recommend against thyroid ablation for nodule with high risk ultrasound features. They are not recommended for thyroid 5. Before thyroid ablation, thyroid and vocal cord function comorbidities must be assessed, and treatment should be evaluated. Laryngoscopy is recommended for patients with hoarseness, previous neck surgery, or with nodule close to critical structures. What is the contraindication? Actually, there is no absolute contraindication for thyroid thermal ablation, but not recommended for patients with thyroid cancer who are good candidates for surgery, because it hidden or slow the progression, which can be misleading for the patient and the physician. Relative contraindication, bleeding tendency, contralateral vocal cord palsy, and the follicular neoplasm. Patient preparation, patient should be fasting at least 6 hours before the procedure. Fluids are allowed. Patient should be given information leaflets. Patient should be aware of the therapeutic response is gradual. Venal line should be established. Aspirin and antiplatelet drug should be stopped 7 to 10 days before warfarin and should be stopped 3 to 5 days before ablation. Warfarin 3 to 5 days, aspirin and platelet 7 to 10 days. Follow-up, we have early term 3 months, intermediate term 6 to 12 months, clinical, biochemical, and the ultrasound evaluation are recommended. Long-term follow-up monitoring is suggested in absence of symptoms every 1 to 2 years in order to reveal regrowth. This is according to European Thyroid Association guidelines. After the procedure, ice pack first day, can return to work next day, analgesic for pain, may experience some skin bruising. In short, we will some points about radiofrequency and the different modalities. What's radiofrequency? A minimally invasive technique, small needle electrode agitate molecules causing heating. Heat destroy the target tissue. It used since 2 decades before. Radiofrequency ablation can reduce the nodule size by 80 to 90% without surgery or hormone therapy. This example of nodule size 33 ml after a radiofrequency ablation with multiple overlapping shoots technique result in highly significant decrease in the nodule size in 3 months. This picture of laser ablation. Laser is focused beam of light energy generated by diode or YAG laser delivered through optical pair into the target tissue. The heat induced changes in the tissue are visible through the appearance, مش بتشاف as hyperechoic signal due to formation of gas microbubbles. The backward repositioning of the pair optic during the procedure allowed destruction of large portion of the thyroid nodule. Percutaneous microwave ablation use alternating electromagnetic field and produce a power of 1 to 150 watt at 950 microhertz. It interacts with the tissue water and ion, leading to local high temperature, and the ablation zone are usually larger than the ablation zone induced by the radio frequency. Cooling systems are needed in case of percutaneous microwave. Doesn't require grounding beds, but radio frequency monopolar require grounding beds. Disadvantage of percutaneous microwave has to be carried out in coaxial cables, which are thicker in diameter than the wires used in radio frequency. Ultrasound, high intensity focal ultrasound is very costly. It spares the extranodular tissue achieved by computer planning of the procedure. Heat is generated by conversion of acoustic into the thermal energy. Computerized mapping of the thyroid or the target tissue in the ultrasound. The ultrasound beam is automatically delivered to the target tissue through multiple shots. The procedure is performed without needle insertion. But the recommendation of the European Thyroid Association, laser and radiofrequency are recommended at the first line therapy, first line treatment modalities. This picture of percutaneous laser ablation in a nodule. In conclusion, the risk of malignancy should be ruled out before before ablation therapy. The advantage and disadvantage of all available options weigh in a dialogue with the patient. Thyroid ablation procedure should not be used for decrease the volume of asymptomatic nodule, no interference for asymptomatic. Spongiform and the complex nodule are better candidate for thermal ablation compared with the solid compact nodule. Ethanol ablation is the most effective and least expensive for cystic nodule. Thermal ablation may be considered for cystic lesions that relapse after ethanol or have significant residual solid components. So we can combine ethanol ablation plus thermal ablation in case of complex nodule who have cystic and solid component. Thyroid ablation should be restricted to benign lesions that cause symptom. Laser and radiofrequency ablation are the most thoroughly assessed technique with similar satisfactory clinical results. Microwave and high-intensity focused ultrasound therapy options remain to be fully evaluated. And finally, thank you for your attention.
Thank you very much, Professor Ghada, for a very clear, comprehensive, and crisp presentation. That's very fabulous. Thank you very much.
Thank you, Dr. Tariq.
Thank you. Thank you very much. And
thank you so much.
It's my great pleasure again to welcome you all to this fiesta of thyroid disorder presentations. Next, we are going to have a talk on differentiated thyroid cancer, case-based discussion, which is going to be delivered by Professor Ali Zahrani. It takes me special pleasure actually to welcome Ali to this particular session. Ali is a very well-renowned figure actually in the endocrine platform of the Gulf. Not only that, Ali is a well-known figure actually on the international thyroid scene. Ali qualified from King Saud University in Saudi in Riyadh early in the 1990s, and he went on actually to be trained in US, and following that, he has rejoined the King Faisal Specialist Hospital and Research Center. Ali is a highly accomplished person. He's very well renowned actually for his very novel research, and Ali, to his great credit actually, has strongly put the thyroid in the Arab world into the international arena. Ali, no wonder, has been the recipient of the International Service Award bestowed upon him by the American Association of the Clinical Endocrinology. It will be very difficult actually just to introduce Ali in few words, and here we are. Ali, the floor is yours. Thank you very much. Ali, are you there? Okay, here we go, Ali.
Rahim, thank you so much, Dr. Al-Had, for your nice introduction, and I really appreciate the opportunity to talk to our colleagues across the Arab world. Thank you very much for the Arab Thyroid Association. So in the next 30 minutes, I'm going to talk about thyroid cancer, hopefully in an interactive case-based management approach. So I have nothing to disclose. And as I mentioned, I will review just a few slides on the important principles of current management of thyroid cancer, And then the rest of the talk will be a discussion of cases as much as the time allows. And hopefully we can interact together. So this is hopefully an interactive session. So as you all know, thyroid cancer has been increasing over the last 40 years for not fully understood reasons, but definitely part of this is the widespread use of ultrasound and other imaging techniques. And you can see there has been a steady increase in the number of cases, not only in the United States, but essentially in every country. Now, what was discovered over the last decade or so is that most of those tumors are small tumors. You can see that tumors less than 1 centimeter has been increasing progressively, 1 to 2 centimeter less steep increase, but still increasing. But when you look at larger tumor, 2 to 5 centimeter, there has been really little increase in the incidence of those tumors, which tells us that basically we are dealing with a large number of small tumors. And the reason for this is most likely the widespread use of ultra-sensitive methods like ultrasound. So you can see more than 2 centimeters, just a slight increase. When you look at tumors more than 5 centimeters, they have not increased over the last 30, 40 years. So obviously, the detection of those tumors became an issue and brought with it dilemmas in the management. So as you can see here, around 50% of tumors are less than 1 centimeter, almost 90% less than 2 centimeters. So people were always wondering if we should treat all of those tumors in the same way. This slide is from Michael Tuttle, who has actually pioneered the changes in the management and what is called paradigm shift in the management of thyroid cancer over the last decade. So basically, the traditional paradigm that we have been working with for the last 20, 30 years is that basically one size fits all, which means basically total thyroidectomy for most patients, giving radioactive iodine for most patients, and we follow them in the same way. What happened in the last 10 to 12 years is that we now follow what is called risk-adapted paradigm, which means your management recommendation is based on the individual risk assessment. So a patient with high risk should be treated more vigorously and more proactively. Those who are low risk should be minimally treated and conservatively followed up. So as I just mentioned, over the last 10 to 12 years, there has been a strong emphasis on assessing risk and predicting the outcome. And we moved from more aggressive approach to a more minimalistic approach, less surgery, less radioactive iodine, less thyroid hormone suppression, and even in some cases and in some centers, just observation, what's called active surveillance. And these concepts became, in fact, they were pioneered actually mostly by Dr. Michael Tuttle from New York in the 2010, 2011, 2013, and were established strongly and advocated and adopted by the American Thyroid Association guidelines that were published in 2015. And there are two disclosures at the beginning of this guideline that I like. One is this one. The major goal of these guidelines is to minimize potential harm from overtreatment in the majority of patients who have low risk for disease-specific mortality and morbidity, while at the same time appropriately treating and managing those who are at high risk. The second disclaimer here is those guidelines should not be interpreted as a replacement for our clinical skills and clinical judgment, and should be used to complement informed, shared patient and healthcare provider deliberations in complex cases. So what they're telling you here is be careful, don't overtreat patients who are low risk, but at the same time, treat adequately those who are high risk. At the same time, don't take the guidelines as Quran, just treat them as guidelines and use your brain and your clinical skills to decide how to treat the individual patient. Now, in this review article that I had the honor to write it with Dr. Tuttle, we looked at risk as a continuous process, starting from the moment you see the patient with thyroid nodule to surgery, after surgery, and during the follow-up. So when we see a patient initially, seeing that I have some technical problem here. Yes, when we see a patient at the time of diagnosis, at the time of evaluation of thyroid nodule, we assess the risk actually. Does this patient need FNA? And if the FNA turns out to be malignant, does he need surgery? If he has, for example, 5 millimeter tumor, can we follow this patient without surgery? Or if we decide to do surgery, what should we do? Should we do lobectomy or total thyroidectomy? Should we do cervical lymph node dissection or not? All of that is risk assessment. After surgery, when the patient goes for surgery and comes to you around 6 to 8 weeks, you have 2 tools to assess his risk again using AJCC 8th edition to assess the risk of death, or American Thyroid Association risk stratification that basically assess the risk of recurrence and persistent disease. And continuously during the follow-up, every time you see a patient after 1 year, 2 year, 3 year, 10 years, we use what is called dynamic risk stratification or response to therapy to decide what is the risk for this patient in the next years. If he's, for example, in excellent response, then he has very low risk of recurrence and death. On the other hand, if he has structurally incomplete response, this patient is at risk definitely of progression and death from his disease. And this is basically the American Thyroid Association risk stratification. So we have 3 grades: low risk, intermediate risk, and high risk. And I'm pretty sure most of you know this. Basically, as you can see here, low risk is intrathyroidal tumor or up to 5 lymph node that has minimal or micrometastases. High risk, on the other hand, is gross extrathyroidal extension or incomplete tumor resection or distant metastases or large massive lymphadenopathy more than 3 centimeters. Anything that does not fit the high risk or low risk is intermediate risk. And you can see here that the risk is a continuous variable. So they wanted actually to cancel those 3 stages, saying that the risk is a continuous process. However, they maintained it so people can communicate with each other on with a clear terminology. The other one is the the AJCC, or the American Joint Committee on Cancer stratification or risk stratification. And again, this assesses the risk of death from thyroid cancer. And it is based mainly on age. So anybody less than 55 years without distant metastasis is stage 1, distant metastasis is stage 2. On the other hand, if the patient is more than 55, then we have stage 1, 2, 3, 4, depending on whether distant metastasis is there, which carries the highest risk, stage 4B. If no distant metastasis, we look at the extrathyroidal extension. If there is no extension, then it's stage 1 or 2, depending on the size and the presence of lymph node. If there is gross extrathyroidal extension, then it depends on how invasive. So it could be stage 2 if it is in the strand muscle, stage 3 if it is in the subcutaneous tracheoesophagus, and it could be stage 4 if it is 4A if it is in the prevertebral fascia or encasing major vessels. Finally, the dynamic risk stratification or response to treatment. Excellent response means basically no clinical, biochemical, or structural evidence of disease, biochemically incomplete when there is thyroglobulin or rising thyroglobulin antibody, but we cannot localize the disease. Structurally incomplete, clearly from the name, when you have basically residual tumor or distant metastases. And then we have also indeterminate response, which basically says that we are not sure if this patient is completely clear of disease. An excellent response. We has biochemically incomplete response. And there are certain criteria that I don't have time to go over them. And this dynamic risk stratification has been clearly shown to correlate with the outcomes. So patients in excellent response enjoy 96% no evidence of disease status, even after a long period of time, after 10 years. indeterminate around 87%. When you come to the biochemically or structurally incomplete, you can see that those percentages significantly decreased to 68% in the biochemically incomplete and to only 15% in the structurally incomplete. You can see that most patients who have who die from the disease are actually in the structurally incomplete. You can see 40% risk of mortality if the patient has structurally incomplete. We have, this is data from, again, Memorial Hospital in New York. We have also looked at this recently, and we looked at the natural course of the response to therapy in our patients. And from this Kaplan-Meier curve, you can see that those who have structurally incomplete here in violet color, they don't do well. You can see most of them, they continue to have a disease and also die, followed by biochemically incomplete, followed by indeterminate, and the group of excellent response do very well throughout. So with that, I'm going to now to try to make, to present some cases and try to make them interactive. So, but we need to test the system. So every time you see this star, it means there's a question afterwards. And here's the first question. And to connect, you can use your mobile just to scan this bar here at the top. Or you can go to this website, slido.com, and enter the meeting number, 059137. So I'm going to give a couple of seconds here for everybody to connect, hopefully, so we can have an interactive session. So the first question here, are you a consultant endocrinologist or consultant other specialties, nuclear medicine or surgery or whatever, a consultant other specialties, endocrine fellow, resident medical student or others. So I hope people will participate so we can make this very interactive and very interesting discussion. This is just to test the system and to make you familiar with the system, but we'll go through interesting cases soon. All right, so again, I think people are trying to enter in the system. Again, if you just put your scanner from your mobile on this bar here at the top, you will be able to enter the group and choose your answers. Okay, so we'll continue to learn this system. So you can see that around 53% here are consultant endocrinologists. Some are specialists. We have some endocrine fellows, and we have other specialties. So I'll move to the next slide, which also will give us an indication where people are practicing. So you're practicing in one of those countries, and this is basically all the Arab countries. So please choose your country. From here, you will see this on your screen again if you connect to this group. I'm going to give again a few seconds. All right. I'm happy that we have people from everywhere. Have people from Syria, Sudan, Jordan, Iraq, Saudi Arabia. Any more? Okay, so I think you see the results in front of you. I'm pretty sure that some people have not yet connected to the system. Again, if you scan this, if you have scanner in your mobile scanning program and you scan this, you'll be able to connect. But you can just put in the website slido.com and enter this number 059137. Okay, so let's move. All right. So I think this is basically what we have. So with that, let's go to the first case. So we have a 29-year-old lady who noticed a left lower neck asymptomatic nodule. And she had no history of external irradiation, no significant past or family history. Her physical examination showed that she was euthyroid with 2 centimeter left thyroid, firm, non-tender nodule. Her TSH was normal. Her ultrasound shows 1.9 centimeter thyroid 4 solitary nodule with no lymphadenopathy. And she had FNA. I think you will all agree that this patient needs FNA. She's young, and she has a solitary nodule of high risk, So again, the risk here, talking about the risk, so thyroid system or the American Thyroid Association pattern recognition system are two systems that are used to assess the risk of malignancy. So this is a high risk nodule, and FNA confirmed the diagnosis of papillary thyroid carcinoma. So again, to keep you alert and interactive, would you do left lobectomy in this young woman with these features? Just one nodule in the left side. Would you do left lobectomy, total thyroidectomy and central neck dissection, total thyroidectomy and bilateral neck dissection, or you suggest surveillance? So again, here we're talking about risk. We are assessing the risk of this young woman with all the features we have, and we have to choose now our approach to the management. And I will go to the choices. So choose whatever you think is appropriate for this young woman with 1.9 centimeter solitary left thyroid nodule, left lobectomy, total thyroidectomy, and central neck dissection, just total thyroidectomy, lateral neck dissection. So far, nobody suggested surveillance and nobody suggested bilateral neck dissection. 6% now, okay. Great. I'm happy of the participation. So most of you choose left lobectomy, and I would agree with that, but let's see what happened to the patient. Well, she came to us actually from another hospital, and the physician there the surgeon chose to do total thyroidectomy. Not totally wrong, but obviously the modern management will choose left lobectomy because, again, of her low risk. However, this patient had total thyroidectomy and she was referred to our hospital. This is the pathology. What you see is actually 1.9 centimeter classical type of follicular thyroid cancer, papillary thyroid cancer, 1.9. There were some lymphovascular invasion. This is the TNM staging, so T1B, which means the tumor is more than 1 centimeter, less than 2 centimeter, NX because no lymph node were removed, MX because metastasis is not known to the pathologist. So the next question here, would you give this patient radioactive iodine? Yes, no, I'm not sure. And here's your chance again to participate in the management of this young lady. So would you give her radioactive iodine or not? All right, so the majority would not, but around 25% will give her radioactive iodine, and I think around 4% are not sure. Okay, let's move. Again, for those who joined late, you can scan this bar here, and you will be able to enter this chat or interactive session. So this is her lab, just in case you want additional information. So her TG after surgery is 2.8, stimulated with a TSH 94, antibodies negative, ultrasound showed nothing, whole body scan is this. So you can see some residual tissue in the thyroid bed, and her uptake is 2.6% at 24 hours. So now that you have this information again, would you choose to give her radioactive iodine or not? I think maybe now, I'm not sure if we can vote on this. Yes, we can. Okay, so now you have additional information. Who would give her radioactive iodine? Her TG is only 2.6. TSH was elevated, ultrasound negative, and scan showed residual tissue in the thyroid bed. All right, so you can see the dilemma that we face in our clinics and the different practice that people are doing. 65 will not give radioactive iodine, 30% will give radioactive iodine. So let's see what we did with this patient. She was not treated with radioactive iodine. The reason for this, as you can see from the pathology, the age, she is stage 1, she is low risk in the ATA guidelines, and therefore I don't think that radioactive iodine is indicated in this patient. She continued to do well, and just to show you her thyroglobulin, this is the 2.8 that was detected at the time of after surgery, 6 weeks after surgery. But you can see throughout her follow-up, she maintained excellent response. TG antibody is negative, and her TG was mostly undetectable, and her ultrasound is negative. So let's move to the second case. Hopefully we can take another one or two cases. So this is a 48-year-old lady who was diagnosed in 2014 with papillary thyroid cancer. And again, she underwent total thyroidectomy, central and lateral lymph node dissection in another hospital. And this is her pathology. She had 3 out of 10 lymph node positive, all small and central in the central compartment. This is the summary of this long report here. And she had classical papillary thyroid carcinoma in the thyroid, multifocal, bilateral. The largest focus was 0.5 centimeter. There was evidence of lymphovascular invasion. 7 lymph nodes in the central region was negative, but remember, she had 3 lymph nodes that were positive, and the background showed Hashimoto's thyroiditis. The pathologist staged this patient as T1A, and that's because the tumor is small. N1A, she has some central lymph node metastasis and MX. So we'll go at the same exercise. Who would give her radioactive iodine? And again, please go ahead and tell us if you are going to treat this 44 or 48-year-old lady with radioactive iodine. Remember the pathology. She had central lymph node, 3 lymph nodes. They were small. She has a multifocal disease. She has lymphovascular invasion. The largest focus was only 0.5 centimeter. So I think the majority would give her radioactive iodine. And I'm not saying this is right or wrong. This is, again, a matter of judgment and the experience. So let's get additional information on this patient. Her TG is only 2.5. TG antibody is undetectable. TSH was at 73.5, sorry here. Ultrasound was negative, so she had a good surgery. And I will show you her scan. Her scan is actually negative. She did not have radioactive iodine before, but she has negative scan here. So I think basically the question whether to give this intermediate risk patient radioactive iodine with negative scan or not. Again, if you look at this patient, where she is on this in this pathway, she is here. Basically, she's on the low risk area, despite some lymphovascular invasion and multifocality. And if you look at the recommendation from the American Thyroid Association, this type of patients with T1 to 3 with N1A, they tell you consider radioactive iodine. So they leave it for you. And depending on the size, number, status, etc. So again, we did not give this patient radioactive iodine. Part of the reason is that she had negative scan, but the other part is that she is still a low-risk patient, and she continued to be stable. And actually, she had excellent response since 2014. This is her latest thyroglobulin, undetectable. And TSH is in the right track. TG antibody is negative, ultrasound is negative. So this is the second case that was not. She has a higher, or let's say more features suggestive suggestive of radioactive iodine therapy or ablation. However, her scan was negative. We did not give her radioactive iodine blindly, and she did very well now over the last 6-7 years. Okay. Let's go to case number 3. I think we'll have time to do it. 25-year-old lady who came with right thyroid swelling, which was asymptomatic. She has no history of external irradiation. Her family history and past medical history were unremarkable. She was euthyroid. She had right nodule about 2 centimeters in the right thyroid lobe, mobile, non-tender with no lymphadenopathy. Her TSH was 1.9. So again, young with 2 centimeter right thyroid lobe, nodule, and an euthyroid biochemically. So what is next? I'm sure from the talk of Professor Rada that the next thing is to do FNA for this patient. This is her ultrasound, and you can see this nodule 1.3 by 1.2 by 1 centimeter. If you look at this nodule, it is heterogeneous, but more hyperechoic. but there seems to be some calcification in the middle. The margins are not well demarcated, so it is thyroid 4. The rest of the thyroid is heterogeneous. She has another nodule that is not shown in this view, but it is a small, only 0.6 centimeter in the left side. It was thyroid 4, no pathological lymph nodes. So FNA confirmed the diagnosis of papillary thyroid carcinoma. So the question, what's next? Should we do lobectomy, total thyroidectomy, or other type of surgery? Again, I want to remind you that this is 2 centimeter nodule in the right lower lobe. On ultrasound, she has another small one on the left side, 6 millimeter, and she has heterogeneous thyroid. She's young, she's only 25. All right, so let's see, more and more. So 70% will do total thyroidectomy, 33 will do lobectomy. All right, I'm waiting for the others, and some of them will recommend other types of measures. Okay, let me tell you what happens. So she had actually total thyroidectomy, central and right lateral neck dissection. Again, this was done in another hospital. However, I assume they found something during surgery. They would not do neck dissection haphazardly. Total thyroidectomy is probably justified because she has bilateral nodules and the rest of her thyroid was heterogeneous. But again, the lymph node dissection is probably done for a reason. And actually, this is the pathology. So she has 3 centimeter right thyroid follicular variant papillary thyroid cancer, and she has 1.1 classic papillary thyroid carcinoma on the left side. She had several lymph nodes that were positive. She had lymphovascular invasion, and the background was Hashimoto's thyroiditis. So this is the T2 N1B. These are lateral lymph nodes, MX. So the question is, what's next? And I will again ask you the same question. Should we give this patient radioactive iodine? No, or we need more investigation. So again, another 10 seconds to choose your answer. This is a young woman with T2 N1B MX. All right, so the majority will give radioactive iodine here. Around 13% would not do it. And you can see some people want to get more investigations. Okay. All right, let's see what investigation you want. So this is the investigation 6 weeks after surgery. Her TG was 63. TG antibody was 13, which is essentially negative, with a TSH of 343. Ultrasound showed she has significant residual in the right thyroid lobe, 11 by 12 by 20 millimeter. I'll show you that in a minute. The left thyroid bed is clear, and there were no pathologically enlarged lymph nodes. This is the ultrasound 6 weeks after surgery. You can see some tissue here. This is the trachea. This is the jugular, carotid, and you can see here a residual tissue, and you can see it better on this. And these are the measurements, 2 centimeter by 1 centimeter by 1.3 centimeter. And this is the scan. The scan again is showing very hot focus, most likely here in this same lesion. And the uptake was 6%. So the surgery was not terribly complete. So the question here, what would you like to do? Would you go ahead and ablate her with or send her for completion thyroidectomy? Would you do FNA from this residual 2 centimeter tissue and then decide, would you just put her in thyroid hormone suppression only? And again, I would like you to decide what to do. All right, can you choose your answer here? Okay, so we have a divide here. The majority want to send her for another surgery. Remember this nodule in the central compartment. So the risk of injury to the recurrent laryngeal nerve for parathyroid is significant. Around 30% will go ahead and give her radioactive iodine. Around 23% will do FNA to decide what to do next. And 9% will just put her in thyroid hormone suppression and send her home and follow her. Okay. I think I just want to discuss this briefly. So completion thyroidectomy is ideal theoretically, but it carries a significant risk to the patient. because of the location. Second thing, when you look at that scan and ultrasound, they are most likely residual normal thyroid tissue. Giving radioactive iodine is reasonable, again, weighing risks and benefits. FNA is also reasonable, but again, it depends on your experience and what you think this tissue is. And thyroid hormone suppression alone is not good for this patient with T2 tumor and lateral lymph node metastasis and some lymphovascular invasion. So we choose to give this patient radioactive iodine, again, weighing the risk versus benefit. And we gave her actually a relatively small dose, only 39, because her uptake was significant, was 6%. This is actually her ultrasound after around 10 months. It has shrunken big time. You can see the report here from 2 centimeter down to 4 millimeter. And this is her scan, follow-up scan after 1 year, and it's completely disappeared. That hot nodule or hot focus disappeared completely. Ultrasound after another year, nothing there, completely negative. And you can see that over the last 4 or 5 years, she maintained excellent response with undetectable thyroglobulin, with undetectable thyroglobulin antibody and good thyroid function test. So I am not going to go to case number 4 because we don't have time, but I'll go to conclusions. So thyroid cancer is remarkably increasing in incidence. Most cases are low risk for recurrence and mortality, but a significant portion of patients can be of high risk, and those are the ones that need active management to avoid morbidity and mortality. The contemporary approach for management is completely based on risk assessment, and we talked about this. Risk assessment is a dynamic process. It's not the same all the time. For patients with low risk, we try to be very conservative and we follow what is called minimalist approach. For patients with high risk, we should be very proactive. We should be very aggressive with those patients to prevent mortality and morbidity. And for patients in between the intermediate risk, we have to individualize our management based on the level of risk and change strategy based on dynamic risk assessment. And with that, I'll stop here. Thank you very much for your attention.
Thank you very much, Ali, for a very fantastic presentation as usual. And before I hand over, the center stage to my colleague, Professor Hussam, I would like just to thank Merck for providing the support for this fiesta of Thyroid Academy webinars, which has been actually quite useful. This is our third sort of batch, and I'm sure few more are coming. And with further ado, I hand over to Hussam Al-Hawari to introduce the last speaker before we move into the sort of case discussion. So the faculty, please stay with us. Thank you very much again, Ali and Ghada. And here we go, Hussam. تفضل.
شكرا دكتور، وأشكر الدكتور علي الزهران على هذه المحاضرة الرائعة ويعطيك العافية. قبل ما أقدم السبيكر الثالث بذكر الزملاء الحضور اللي عنده أسئلة يتفضل يكتبها يبعثها، احنا بنسجلهم لأنه عندنا آخر نص ساعة أسئلة وأجوبة نوجهها للسبيكرز. السبيكر الثالث البروفيسور مالك جويعد، Professor of Radiology and Nuclear Medicine, University of Jordan. He's a clinical fellow. He was a clinical fellow in nuclear medicine, University of Pennsylvania, Harvard University, and in Germany. هو الإديتور إن شيف للجوردن ميديكال جورنال. نفتخر فيه بوجوده كزميل في الجامعة الأردنية، وهو من الزملاء الأكثر استشهادا في أبحاثهم. دكتور مالك تفضل.
Well, thank you very much, Hussam, for this kind introduction. Thank you for inviting me to give this presentation. It's truly an honor. I'd like to just emphasize at the beginning that I will not be able to cover radiology imaging in thyroid imaging with all radiological approaches. It will be focused It's really on nuclear approaches, so it's nuclear imaging. You're all familiar with the most basic nuclear imaging approach of the thyroid, namely thyroid scintigraphy. It's now almost everywhere done with technetium-99M pertechnetate as an iodine surrogate. When available, however, iodine 123 is certainly a good alternative. We do use at our institution and elsewhere small amounts of iodine 131, 5 to 10 microcuries to determine the uptake of thyroid at 24 hours, sometimes also at 4 to 6 hours. As you know, the normal range in our region is 10 to 30% at 24 hours. We can summarize thyroid scintigraphy in a few words. It provides truly a map of functioning thyroid parenchyma. So the major applications there are straightforward. The first one is functional characterization of thyroid nodules as hypofunctioning or cold nodules versus functioning hot or warm nodules. It's no longer useful alone. It can't be really used alone without ultrasound, but combined with ultrasound, it does help determine which thyroid nodules should be characterized further with fine needle aspiration. It's pretty much a consensus worldwide that warm or hot nodules are rarely malignant and they really rarely need fine needle aspiration. The other application is the differentiation between various causes of hyperthyroidism, especially in difficult cases. So this is an example of a patient with Graves' disease with uptake of 70%. Yet we can see here two cold nodules. One in the right inferior right thyroid lobe, another in the upper to mid left thyroid lobe. They are clearly worrisome in the context of Graves' disease. Ultrasound, however, showed isoechoic nodules with cystic degeneration, but they were intra and perilegional increased flow. So the patient had a FNA, and it was a Bethesda 2. It was benign changes, essentially cystic degeneration and colloid. And nevertheless, patient went several months later and had, as a young patient, had thyroidectomy for treatment of Graves' disease, also to address the nodules, and the nodules were found to be benign. So malignancy in Graves' disease is overstated in many publications. A meta-analysis showed that that average number is about 7%, so right around 10%. But cold nodules clearly need attention with ultrasound. The famous or the well-known reasons for cold nodules are thyroid cancer, cystic degeneration of nodules, including autonomous nodules, and pure cysts. But there are sometimes some unusual reasons, like in this patient who had a cold nodule in the inferior right thyroid lobe, extending into the isthmus. The ultrasound showed a heterogeneous hypoechoic nodule with increased flow, suggestive of focal thyroiditis. And indeed, the clinical picture was suggestive of that, and the radioiodine uptake was 6.8%, so clearly low, unusual reason of cold thyroid nodules. I'll give a small case study here of the usefulness of thyroid imaging, thyroid scintigraphy, for differentiating various causes of hyperthyroidism. I am sure most of you, if not all of you, have seen this scenario. As a female patient with symptoms of hyperthyroidism, suppressed TSH, elevated FT4, physical exam shows painless thyroid and normal size or only slightly increased in size. ESR is normal, anti-thyroid antibodies are pending. And that can take a few days, at least 1 to 2 days, until the antibodies are back, the autoantibodies are back. So what do you do to quickly establish the diagnosis? Most of you would order a thyroid scan, And there are here two scenarios, either increased uptake in both thyroid lobes, as you see here, consistent with Graves' disease, or no uptake whatsoever in the thyroid region, consistent with autoimmune thyroiditis in this case. So thyroiditis versus Graves can be addressed. It will take only 20 minutes for the scan. You inject the pertechnetate, 20 minutes later you have the image. If you have good relationship with the nuclear medicine department, you can do all of that within an hour or so. This is a case of toxic multinodular goiter. You see here the hot nodules, the warm nodules, and the remainder of the thyroid being suppressed. The classic toxic adenoma here in the right thyroid lobe with complete suppression of thyroid tissue. This is before therapy with radioactive iodine. On the left here and on the right, you can see that the hot nodule became cold and the normal thyroid tissue came back. So the other thyroid imaging modality, nuclear imaging modality, is radioactive iodine imaging. And this is also familiar to all of you, but maybe not everybody knows that iodine 131 is not the only imaging modality used, but rather others like iodine 123 that's used in many countries. It's a little bit expensive and not readily available, but it produces better images because it's a gamma emitter, pure gamma emitter. And then you have iodine 124, which is a positron emitter. So you can do PET scans with it, iodine 124, PET CT scans. And these also have high contrast and resolution. So we're familiar, obviously, with the iodine 131 whole body scan that's typically performed 3 to 7 days after therapy with iodine 131. Because of more accurate staging, we can upstage some patients, not very high, but a certain percentage of patients, maybe around 10-20%, where we discover lymph node metastasis or distant metastasis on the scan. So it helps in the staging process. And also the diagnostic iodine scans with iodine 131, iodine 123, or iodine 124 can be done or are usually done at 6 to 12 months following iodine 131 therapy to determine the response status, as the previous speaker alluded to, the excellent response in complete biochemical, structural, undeterminate response. This is an example of a patient who had...
دكتور مالك بس ممكن تحط الكيرسر للسادة الحضور تبين
اوكي اسمه هاي هون مثلا. Okay, this is a patient with thyroid cancer, with papillary thyroid cancer, who had lymph nodes at presentation. And here is the scan 1 week after treatment with 150 millicuries. You can clearly see thyroid remnants, benign thyroid remnants, and lymph node metastases. And following treatment here, following treatment, 9 months following treatment, you do not see any uptake in that region. So this, in combination with normal thyroglobulin and normal ultrasound, would give the patient an excellent response designation. So the other application of radioiodine imaging that's being favored in some places, for example, in Michigan, University of Michigan, which is one of the really strong places for thyroid imaging and therapy, is in the theranostic, meaning to use the same radio tracer or similar radio tracer in diagnosis and therapy, so to predict what will happen during therapy. So that's basically the principle of theranostics. And here we can use radioiodine imaging to better inform decision regarding the type of therapy to give. So we would do a pre-therapy iodine 123 or iodine 124 scan, or even iodine 131 scan. and see what we see basically. If it's only in the thyroid, then we would give remnant ablation. If it's elsewhere, established disease, then it's known disease, we would give a higher dose. We use that not alone, but also with the clinical pathological information that we have. So this approach is justified by data showing that radioiodine imaging before therapy can change staging and risk recurrence stratification in 15% of patients, and change the how much iodine we will give or how we will give it in 31% of patients. This approach can be achieved in any contemporary practice, particularly if they have SPECT-CT, the high-end, high-resolution imaging. This is an example of a patient here who has papillary thyroid cancer, had small lymph node metastases that were resected, and nobody thought that he would have any metastases after the thyroidectomy and central lymph node dissection. Yet we see here the residual thyroid tissue, and higher up and laterally we see what looks like a lymph node. This is a SPECT-CT scan. Here is the fused CT and iodine scan, and you can see increased uptake here corresponding to a lymph node, about 1 by 0.5 centimeter lymph node, and while down here you will see increased uptake in the thyroid bed alone. So with this, we decided, this was a pre-therapy scan. With this, we decided to give a patient a high dose of 150 millicuries to treat known established disease by our imaging modality. So other imaging modalities in thyroid imaging are actually quite a few, but the important ones are Fdg Pet Imaging. And the main application here is to detect occult metastases in patients with iodine negative whole body scan and elevated thyroglobulin, or undetectable thyroglobulin but elevated anti-thyroglobulin antibodies. And here is a recent or 2016 meta-analysis showing that this imaging modality is quite good, quite accurate, with pooled sensitivity of 93% and specificity of 81% when using PET-CT, which is a little higher than when using PET alone, where it was like around 84%. Other contribution in a certain way of Fdg PET is being an incidental finding in the thyroid. So as you know now, PET is widely used for staging and restaging of most cancer types. And in many cases, not in many cases, but in at least 1 to 2% of cases, there is a finding on in the thyroid on the Fdg PET scan. And this can be diffusely increased uptake, which is seen in both autoimmune and painful thyroiditis, or it can be focally increased uptake that is associated with malignancy in about 35% of cases. So the ATA recommends FNA for all hot nodule on Fdg PET scan that are greater or equal to 1 centimeter, whereas other diffuse increased uptake is not worrisome and does not need further workup. Interestingly, these thyroid incidentalomas are not only seen with Fdg, but also with other modalities such as gallium-68 DOTA, that's a somatostatin imaging agent, gallium-68 PSMA PET for prostate cancer, and fluorocholine for prostate and parathyroid imaging. So it's not unique. The hot focus is not unique to Fdg, and in all these cases, it needs further attention. This is an example of a patient who had a hot nodule here. It's focal, so that needs further FNA, whereas the other patient has diffusely increased uptake, most likely autoimmune thyroiditis. This is a patient from our institution where we, with a patient with lymphoma, you can see the large mediastinal mass here, and you can see the right nodule with high Fdg uptake with an SUV of 9. It was biopsied and turned out to be papillary thyroid cancer. So let me move to parathyroid imaging. Again, I'm going to be focusing on nuclear approaches, and it looks like there are many. These are dual phase technetium-99M system EB, by far the most widely used radio tracer in parathyroid imaging. You can do planar imaging, so meaning non-tomographic imaging, high resolution parallel hole collimator, the regular way of imaging. And you can do pinhole collimator imaging using pinhole collimators that will magnify the image and also result in high resolution, and SPECT imaging, single photon emission computed tomography, that's basically tomographic imaging. Then you have a combination of technetium-99M system EB with thyroid imaging with technetium pertechnetate or iodine 123. This is called dual tracer imaging. It's often combined with subtraction imaging, where you subtract one picture from the other. Then you have technetium-99M SPECT CT, combination of SPECT with CT in one single instrument. Then you have a C11 methionine PET CT and fluorine 18 fluorocholine, as well as C11 choline PET CT. So at our institution, prior to acquiring a SPECT CT, we used pinhole imaging. And in fact, we were supported by publications, including our own, that showed that pinhole imaging is more sensitive than the planar parallel hole imaging, and even more sensitive than SPECT alone. However, when you could compare it with SPECT CT, it becomes less sensitive. So our protocol here is to do the initial an early image at 5 to 10 minutes or 10 to 15 minutes, and then a delayed image at 2 to 4 hours, and then to do also an image of the entire thorax with parallel hole imaging so that we don't overlook an ectopic adenoma, which, as you know, can go from the carotid sheath down to the pericardium. And in many cases, we do also a thyroid scan with pertechnetate for comparison. So as you can see here clearly, there is a focus of increased uptake in the inferior to the inferior pole of the left thyroid lobe that persists on delayed images. And that's like a left inferior pole parathyroid adenoma. That's the classic. And it's also mismatched with the thyroid. It's not seen on the thyroid scan. This is another patient who had an ectopic parathyroid adenoma here, somewhere midway between the upper pole of the left thyroid lobe and the salivary gland, the submandibular salivary gland. Of course, a SPECT CT here would give the location much better. But notice here that the parathyroid adenoma actually washed out relatively fast. Actually, it washed out fast. We can't see it on the delayed images. So these are the so-called rapid washout parathyroid adenomas. We should not jump to the conclusion, say that this is thyroid abnormality. Obviously, here the location suggests that it's not thyroid abnormality, but having a thyroid scan would be reassuring that this is a clearly mismatched finding. It's seen on the early system EB image, but not on the thyroid. So this is a parathyroid adenoma, and it does not matter that it washed out fast. Here is another case of a patient with secondary hyperparathyroidism, where we see three parathyroid hyperplastic parathyroid glands, one just inferior to the inferior pole of the left thyroid lobe, one looks like in the superior mediastinum on the right and one just in the inferior neck. So here again, they wash out relatively fast, and this is known. Hyperplastic glands tend to be smaller than adenomas and wash out faster. So the fast wash out should not deter us from calling them, and we're reassured here by looking at the thyroid scan. They are mismatched. There is no such abnormality on the thyroid scan. Okay, this is an interesting case of a patient who had a scan at our institution, and we've seen an abnormality in the just inferior to the inferior pole of the right thyroid lobe. But also here you can see very faint uptake on the left that you would tend to discount, but it's not seen on the thyroid scan. It's not, there is no matching abnormality. So we suggested that this might actually be another adenoma, but seeing that it was faint and it's not there on the delayed image, whereas the right one is clear cut, the surgeon went ahead and did surgery only for the right adenoma. Patient continued to have elevated parathyroid hormone level, and sure enough, several months later, we imaged, and the patient clearly shows now the left parathyroid adenoma. So the take-home message is pay attention to the mismatch with thyroid whenever in doubt, and rapid washout should not deter you. This is the same patient having a SPECT CT scan clearly showing the left inferior pole parathyroid adenoma here on the coronal images, and you can see it on the axial images also posteriorly. So this is a SPECT CT, basically a fused image, fusing the system EB image with a CT image. Okay, now having talked about so many modalities, nuclear modalities even, for imaging the parathyroid, what's the best? And this is a very elegant study that was just published in JAMA Otolaryngology in 2021, in June actually, that was a meta-analysis, so-called network meta-analysis that compared many imaging modalities. And the criteria were studies that compared two imaging modalities in the same patients, two or more imaging modalities in the same patients. And then they calculated the so-called, this was over many, many years since indexing began, basically since parathyroid imaging began. And they calculated the so-called SUCRA value, which is the surface under the cumulative ranking curve. The number here ranges from 0 to 1, gives you the probability that this imaging modality is the best, is the most effective imaging approach. And as you can see here, for the entire period, choline PET CT was on the top with a SUCRA value of almost 1. Methionine was actually the third. The second was, interestingly, CT, in this case, 4D CT, 4-dimensional CT. In good hands, it's quite good. And then the fourth was maybe SPECT. And this maybe SPECT actually even included SPECT CT. When we look at the period after 2010, pretty much the same picture with fluorocholine being first and CT again 4-dimensional CT, 4D CT being second. Only if you look at the period prior to 2009 was maybe SPECT the best, and in particular because of the use of SPECT CT. So one might argue that nowadays, if you have access to choline PET CT, you should just go ahead and use it. Also 4D CT and especially if you have the people who are experienced and see high volume, because it's not easy to interpret, and so you need quite experience. But if you don't, then the best next choice would be clearly SPECT CT, maybe SPECT CT, clearly better than MRI and other and planar imaging modalities. So finally, I cannot leave you without showing you the king, namely fluorocholine. This is a patient who had several surgeries looking for parathyroid adenomas for really severe hyperparathyroidism with high calcium. And as you can see here, there is this is the system EB SPECT. And you can see the thyroid and the salivary glands. You don't see any parathyroid adenoma. This is a SPECT. This is a SPECT MEB. However, when you do the fluorocholine, clearly you can see here this abnormality with very high uptake. This was actually an intravagal parathyroid adenoma in the vagus nerve. These images here show that it is between the internal carotid artery and the jugular vein right here. It's about 7 millimeter. So this is the high contrast that you can get with fluorocholine, and it's really no wonder if combined with the PET technique that it is the state-of-the-art imaging of a parathyroid. Thank you for your attention.
شكرا دكتور مالك. بس was this parathyroid remover adenoma removed?
Yes, and patients' parathyroid hormone level normalized completely.
Interesting. شكرا للمحاضرة الرائعة والنايس كيسز. وصلنا ما شاء الله أسئلة عديدة راح نتناوب نوزعهم على السبيكرز أنا والدكتور طارق. بس ببلش مع دكتورة غادة. السؤال الأول: for the partially cystic nodules, would you depend on the size of the whole nodule or the solid component only?
For the cystic nodule, if it's eccentric solid component with ultrasonic characteristic of malignancy, should be considered, not only the size. So again, if we have cystic nodule and the eccentric solid component who have suspicious criteria on ultrasound finding, this is also considered high risk.
Okay, thank you. Dr. Tariq?
Yes, thank you very much. Question to Dr. Ali from one of the delegates. How soon you can do ultrasound post-thyroidectomy?
Okay, so the question is how soon you do ultrasound after thyroidectomy. After thyroidectomy, it's not uncommon to see some reactive lymph nodes. Therefore, if there is no urgency, I would recommend 6 to 8 weeks. However, it all depends on the management requirement. I would say after 1 month, things should be okay. However, you have to be aware that you may have some edema, you may have some adhesion, you may have some reactive lymph nodes, but these should be kind of relatively easily recognized. So after a month, if I have to give a direct answer.
Okay.
شكرا دكتور. سؤال الدكتور مالك: what are the sensitivity of parathyroid image among different modality in case of chronic kidney disease, and what is its role in surgical intervention?
Okay. Sensitivity, except for a few things, is terrible. For planar imaging, even pinhole imaging, SPECT alone is probably, so this for secondary hyperparathyroidism, secondary hyperplasia, or even multiglandular disease in the primary hyperparathyroid setting, primary hyperparathyroidism setting. So it's maybe around like 30%, 40%. However, it is better with SPECT CT. It goes like up to the 50%. The only modality that clearly is showing, two modalities that are clearly showing progress with the multiglandular disease with hyperplasia are 4D CT and fluorocholine, where it might actually be in the range of 80 to 90%. role of the role with surgery. I didn't understand the second part of the question.
What is the role of surgical intervention in chronic kidney disease?
Well, is it like in the context of tertiary hyperpara or what?
صراحة مش واضح السؤال.
يعني مش واضح.
ممكن يتبعوا الجايد لاينز العادية زي ما تفضلت سواء برايمري أو تيرشري هايبربارا. Just follow الكيدوغي guidelines أو endocrinology endocrine society.
Yeah, I think we must rely on the old criteria: the phosphorus level, calcium level, 25 hydroxy vitamin D level. Then they try the medical treatment first with the different lines of management, either phosphate binder, vitamin D, and we see the results. If the paras hormone within the accepted range, I think about 300, it's okay. If it's still high and not responding to medical treatment, they go through surgery.
صحيح هي الكيدوكي guidelines النفرولوجيست they follow but again it's step by step. شكرا دكتور مالك. شكرا دكتورة غادة.
Okay. Next question to Professor Ghada regarding toxic adenoma and high suspicious features on ultrasonography. FNA indicated in this condition?
If the thyroid, the TSH level is suppressed, we'll do so. Thyroid scan well done. If there is hot nodule, unlikely to have malignancy. And this next is different treatment of functioning nodule, either medical or radioactive iodine therapy.
So you won't embark on any FNA in this circumstances, in this particular.
You don't go through FNA.
Yeah, absolutely. Thank you very much.
سؤال للدكتور علي الزهراني: which should be done first post thyroidectomy, thyroid ultrasound or whole body scan with ablation? يعني بيسأل should ultrasound and thyroglobulin be done before whole body scan with ablation to make sure no residual lymph node requiring second surgery. أعتقد عرضنا بعض الحالات بس تفضل دكتور علي.
Yeah, so basically you don't have to do ultrasound if you have a complete surgery. You can do just if you plan to give the patient radioactive iodine, you can just do thyroglobulin and a scan. Now, if the scan or thyroglobulin suggests significant residual, then you can do ultrasound. In our hospital, because again of the availability, I would say we routinely do both. But if you have shortage of resources and you want to be more conservative, then I would say you do serum thyroglobulin stimulated and you do a whole body scan. And if you see reasonable elevation of serum thyroglobulin, let's say below 20, and the scan is showing just an uptake in the thyroid bed, then you can go ahead and ablate with radioactive iodine. If there is something that suggests significant residual disease, for example, very high thyroglobulin or ultrasound or a scan is showing uptake outside the thyroid bed, significant uptake, then you may need to do ultrasound to make sure that you're not ablating gross disease, high volume disease.
شكرا دكتور علي.
Okay, another question to Dr. Ghada. What about thyroid nodules and pregnancy? How can we deal with that?
Thyroid nodule with pregnancy, we proceeded the same algorithm, except the scan is contraindicated during pregnancy. If there is high suspicion for malignancy, FNA, we can do it. We can, if there is not high risk, we can postpone post-pregnancy. If it's not high risk, if there is high risk, can maybe done in mid-trimester surgery. So radioactive iodine is contraindicated during a pregnancy scan. If it's high risk for malignancy, we can do operation for mid-trimester, if not postpartum.
Thank you very much. Thank you.
دكتور غادة, we're keeping you busy. كمان سؤال إليك حضرتك تفضلي: which is better to depend on American Thyroid Association or TRAT system for risk assessment of thyroid nodule?
The difference is not big, it's made so big between the European and the American Thyroid Association. Thyroid system is very applicable and now widely used by radiologists, and we rely on thyroid system classification. But not big difference between both.
بتفق معك يعني في overlap.
Dr. Ali, in this situation, Dr. Ali can tell us.
Yeah, as you said, Professor Ghada, both of them are good as long as you know how to use them. So if you are accustomed to the American Thyroid Association system and you're comfortable with it, that's fine. If you are accustomed to thyroid system, it's fine. I think thyroid system is more objective, so it gives scoring for different features. Do you hear me?
Yes.
But the ATA recognition pattern recognition is also very good. So I think there are some studies comparing both of them, and they are comparable in reality.
And I would just
Most
criticize.
People are using thyroid. Actually, I think our Professor Malik can add to this. He's the radiologist, and I'm sure he will support the thyroid system.
That's what, as you said, everybody uses. It's widespread, and it's.
And I agree with the thyroids, but I think I would criticize it لما تكون 4 millimeter nodule, very tiny, and they follow the thyroids. They're really suspicious. And لما تكون very tiny nodule شوي, I have difficulty doing thyroids. I would follow the ATA actor or microscopic nodules. Dr. Tariq, تفضل.
Okay, question this time to Dr. Ali Zahrani. 39-year-old male, thyroid nodule 2x2, isoechoic, no lab test or other, no lymphovascular invasion or other invasive features. Other lobe is normal looking with suppressed TSH and elevated T4 thyrotoxic symptoms. Possibly the question here is just focusing on suspected malignancy in a case of possible Graves. What should be my next step?
So as I think Dr. Ghada explained in her lecture, those patients, the first test should be thyroid scan and uptake. Now, what are the possibilities? The number one, you may see a hot nodule and the rest of the thyroid is suppressed. So that's a clearly toxic adenoma, and the risk of malignancy in those clearly toxic nodules where you have very high uptake in the nodule and the rest of the gland is completely suppressed is very minimal. So in this situation, usually we don't need to do FNA, although there are case reports from time to time. But if I have clearly toxic adenoma, hot nodule in that nodule and the rest of the gland is suppressed, this is a patient with toxic adenoma. He's hyperthyroid. He needs to be treated either with radioactive iodine or with surgery. The second possibility is you do scan and uptake and you see that the thyroid itself is hyperactive and the nodule itself is hypoactive or cold or sometimes warm, as they call it. This is usually Graves' disease with cold nodule, and this needs to be biopsied because it can be cancer in the middle of Graves' disease. So for hyperthyroid patients, the first test is the thyroid scan and uptake. And based on the pattern, you will decide whether to do FNA or just treat with the radioactive iodine or surgery. Toxic adenoma versus cold nodule that needs further assessment like any other nodule. Maybe Dr. Ghada can add to this if she prefers.
Okay, Dr. No.
Thank you.
Fantastic. Hussam?
سؤال الدكتور مالك ممكن الزملاء يساعدونا. A patient with 1.4 centimeter thyroid nodule with microcalcifications. عملوا له thyroid function, suppressed TSH, elevated T4, positive TPO antibodies, negative TSH receptor antibodies. Thyroid scan showed high uptake in left lobe, left hot nodule. Would you do FNA for this patient?
No.
This is a left hot thyroid nodule. Maybe in the setting of Hashimoto thyroiditis, hashimotoxicosis.
I think
أعتقد كنا متفقين it's hot nodule, no need to. تفضل دكتور طارق.
Yes, another question to Dr. Ali. the delegate asked him specifically, I think he's referring, Ali, to one of your interactive cases. He said, you know, regarding the case was lymph vascular invasion not considered intermediate risk and need low-dose radioiodine therapy?
So lymphovascular invasion comes in different format. If this is a small lymphovascular invasion, which is usually the case when the pathologist does not say large vessel invasion, it is intermediate risk, but it's not by itself an indication to give radioactive iodine. So if you have a small vessel invasion, especially when they are less than 5 vessels as defined by, then this is again relatively low risk, and it's not by itself an indication to give radioactive. So it's true when you have lymphovascular invasion that it brings the stage to intermediate, but not every intermediate risk needs radioactive iodine. We take in consideration different factors: the age of the patient, the presence of lymphadenopathy, the investigations after surgery, including serum thyroglobulin, ultrasound. So that patient was clear otherwise, and this is why we just decided not to give her radioactive iodine to follow it.
شكرا. كمان مرة دكتور علي. After thyroidectomy with suppressive thyroxine therapy, at which time we stop suppressive therapy, يعني نخفف الدوز? And do we do stimulated thyroglobulin by high TSH?
Okay, so for thyroid hormone suppression, it again depends on the risk. So if you have a patient, when you see a patient after treatment, and you can decide if the patient is in structurally incomplete, then definitely we want to suppress TSH to undetectable level. If the patient has biochemically incomplete, that's also an indication for suppression. But if the patient is in excellent response or indeterminate response, you don't need really suppression. Those patients do well on a target of 0.5 to 2 microunit per liter. So it all depends on whether there is a disease or no disease. If there is no disease, no clear evidence of disease, you don't need suppressions. Again, in the last decade, we are less active with suppression. We are more reasonable with suppression, especially for patients who have clear situation, excellent response or indeterminate response.
Okay.
I think there was another question, or
في كمان بس الدكتور طارق بوجه السؤال.
Yes, it is a different question. This delegate Ali asking you, a patient with 2 centimeter, possibly he means tumor, who underwent lobectomy. Pathology showed aggressive histology with microscopic ETE. Should patient undergo complete thyroidectomy?
Okay, so if there is aggressive histology, let's say tall cell variant or columnar cell variant, and there is an extrathyroidal extension, yes, this patient should go for completion thyroidectomy. However, I must say that the most common indication to go for completion thyroidectomy is usually large vessel invasion. Because large vessel invasion, you cannot see it, you cannot, predict it. So around, in good center, around 20% of patients who do lobectomy go for completion thyroidectomy because of the finding of pathological examination of large vessel invasion. So, but the described 2 centimeter aggressive features, yes, those patients, I will send them for completion thyroidectomy because I think this type of patients need radioactive iodine. I don't want people to live with the wrong message, because this is common. You know, before 10 years ago and before, we were treating everybody aggressively. In the last 10 years, we want to be more rational and more conservative. But some people misunderstood this as be very conservative with every patient. I think this is why I presented those 2 statements from the guidelines. I think your role as a clinician is to filter out those who need aggressive management from those who needs conservative management. So for those with high risk features, be proactive, be more, I don't want to say aggressive, but more attentive to the management. Do complete thyroidectomy, do a lymph node dissection if necessary, give them radioactive iodine, maintain good suppression until you are sure that those patients are clear of the disease. And this usually represents around 15, maximum 20% of patients. 80%, we don't want to be very aggressive and over-treat them and expose them to the risks of the treatment. We want to be more rational in their treatment. So this is the whole concept of risk stratification and risk-based management. If you have very aggressive tumor, treat it very aggressively. If you have very low-risk tumor, treat it very conservatively. If you have in-between, use your judgment, knowledge, and expertise to decide who needs aggressive or more aggressive management and who needs more conservative management.
دكتور علي وبتفق مع دكتور الجايد لاينز نزلت من مايو كلينيك يعني even if you choose to do conservative management this does not mean no follow up بدك تعمل follow الجايد لاينز الالتراساوند الثيروجلوبولين we decide إذا عندك خايف he may lose follow up no I would rather give him radioactive فهذه الستاندرد بدك تتأكد أنك you can follow the standard.
Absolutely. That's what I'm trying to say, Dr. Hassan, that we should not be so extreme with the guideline. We should, the guideline does not tell us dismiss those people, does not tell us don't care about those people. The guidelines give you a roadmap and you should follow this roadmap, but you should be very careful not to miss some patients. You have to treat them appropriately.
صحيح. السؤال يتبع للحالة اللي قبلها للدكتور علي. احنا حكينا do you ablate for microscopic extrathyroidal extension or microscopic positive margin؟ بسأل هل في فرق بين ال ATE والmicroscopic positive margin؟
So the microscopic extension was in the AJCC staging version 7, was immediately putting patients in stage 3. This is the change in AJCC or TNM classification version 8. They found that the microscopic extension does not add much to the risk, and therefore it is not considered in the AJCC TNM version 8. So I would say in general, microscopic extension is not considered very seriously. Macroscopic or extensive extension is important. One exception to this, in pediatric thyroid cancer, microscopic extension was found to correlate very well with lymph node metastasis. So it's taken more seriously in pediatric thyroid cancer, but not in the bulk of adult thyroid cancer. We don't pay a lot of attention to it currently because of the change that happened in the TNM version 8.
نحكي هلا احكي
تفضل دكتور مالك.
Yeah, I just wanted to add that we actually looked at the distribution of low risk, intermediate risk, and high risk in a Jordanian population, like at the University of Jordan, over the last 10 years. And the distribution is 43% low risk, 43% intermediate risk, and 15 high risk. So there are, if you are more like aggressive and want to treat the high risk and intermediate risk, there are plenty of patients to treat. It's not like everybody is low risk. Only 43% are low risk. And we actually published that in Endocrine. And we take the same approach as Dr. Ali said, but we tend actually to treat more the intermediate risk patients, especially the high-end intermediate that are closer to the high risk. And in fact, I must admit that the ones who pushing us to treat are the endocrinologists and surgeons. So even if we want to be more conservative, there is a trend from the surgeons, especially, to push for radioactive iodine, unless it's clear cut. I mean, less than 2 centimeters, they don't treat anymore. but in the intermediate category, in general, they want us to treat. That's all.
Okay, thank you very much, Dr. Juwaid. This question could be actually for both of you, Dr. Ali and Dr. Ghada. Ultrasound showed moderate in large lobes. It's rather actually long question, multinodular goiter. Thyroid nodules in the right lobe, measure 3 by 2 by 1.8 centimeter. Ultrasound guided FNA from right lobe showed picture consistent with chronic lymphocytic thyroiditis. Initial TSH was suppressed, less than 0.05, with high free thyroid hormone T3 and T4. Carbimazole was given for 3 months. Now TSH was elevated at 13, and FT4 is probably just normal at 9.9. What is the appropriate intervention now? Thank you. Sorry, it is a rather long question. Okay.
Should I?
Okay.
So you have multinodular goiter with hyperthyroid state. So again, I think that came in the presentation of Dr. Ghada, and also we alluded to in our discussion. Those patients should have actually thyroid scan, because you are likely to find a number of scenarios. This could be toxic multinodular goiter, period. And that's a clear diagnosis. This could be, you could find toxic multinodular goiter, but with large dominant cold nodule, which needs to be investigated further with FNA, because the fact that the patient has multinodular goiter does not mean he or she is immune from thyroid cancer. So if you find prominent cold nodule in that scan, you need to do ultrasound and then FNA of that nodule. So I think that the patient, treating that patient with methimazole without further investigation is not necessarily the right way to do it. You need a scan and maybe even ultrasound from the beginning to define the anatomy, but the scan would be of great help. If the scan is just showing you typical multinodular goiter as presented by Dr. Malik in some cases, then that's it. That's toxic multinodular goiter. But if you find a prominent cold nodule somewhere there, let's say most of the right lobe has this big nodule is in the right lobe and it's cold, then that could be cancer, and you need to do FNA. You need to do ultrasound, and then if the features are consistent with the high risk nodule, you need to do FNA.
And I think
Dr. would like to add something. Okay, go ahead.
يعني with ultrasound for multinodular goiter, not choose the biggest one. We choose the most suspicious one. Maybe the biggest one is not characteristic of malignancy or suspicious, so you need to do FNA. FNA can be done in a smaller one with high characteristic ultrasound.
Absolutely. So the size is not the indication; it is actually the ultrasonographic features. Except in this case, if they do scan and the scan showed a dominant cold nodule, then that needs to be pursued.
Sam?
أشكركم جميعا. أشكر شركة ميرك for sponsoring this activity. أشكر my co-chair person دكتور طارق الهد. أشكر السبيكرز بروفيسور غادة الصغير، بروفيسور علي الزهراني، وبروفيسور مالك الجويعد. أرجو أن تكون محاضرات مفيدة، وإن شاء الله نتابع معكم نشاطات الجمعية العربية لأمراض الغدة الدرقية.
إن شاء الله. Thank you.
شكرا لكم جميعا.
Thank you very much. شكرا لكم جميعا. Nice to have met you. شكرا لكم جميعا. شكرا يا علي.
مع السلامة.